My name is Pedro Garcia. I'm a technical director in the R&D team at Boston Scientific. I am very pleased to be with one of our key physicians, Dr. Peter Littler from Newcastle, to talk to you about beads innovation. And I'm going to be walking you through the innovation and development that has taken our technical team to develop DC Bead LUMI, having developed and launched DC Bead some years back. And Dr. Peter Littler will be walking through his clinical experience, having been using the product for a few years now. Please note that we've got a Q&A function up and running, and please take the opportunity to capture any questions on that as we're presenting, so that when we get to the end of our presentations, we'll be able to start having some discussions and answering your questions. So, with no further ado, I just want to give a little bit of background as to the development of DC Bead some 15, 16 years ago now. And we were really looking at the therapy that was being used to treat primary liver cancer. And as we all probably know, about 30 years ago or so, in the Far East, in Japan in particular, there was development around using a more targeted way of treating liver cancer. And that was with the combination of lipidol, a substance that I'm sure you're all familiar with. It's a radiopaque entity and can be mixed with different chemotherapy agents and injected directly through intravascular access into the tumors in the liver to concentrate the drug, the chemotherapy, and reduce the systemic exposure to the patient. And this to this day continues to be a very popular treatment therapy and very effective. But with the development of DC Bead, we really looked at some of the downsides of conventional TACE. And DC Bead was developed to optimize the targeting of the chemotherapy to the tumor itself, whilst reducing the systemic exposure. And then the next step from that we've taken is to enhance that product, the DC Bead product, to actually make it radiopaque and give it additional features to be used as an effective tool in the same therapy. So just very briefly, Precision 5 was the first randomized controlled trial in this area. And despite not having reached its primary endpoint, there were some very clear benefits. There was reduced systemic exposure was demonstrated with a reduction in severe adverse events. There were fewer drug-related issues. And for a particular cohort of the patients, there were some significant advantages with advanced patient, BCLB type patients. And more than anything, despite not having reached its endpoint, it did set the scene for interventional oncology, and it was the first randomized controlled trial for drug-eluting beads. So we really kind of started trying to understand what would be next. What could we do beyond drug-eluting beads? And as we all know, conventional beads, whether they're bland beads or drug-eluting beads, are not radiopaque. They're not imageable under X-ray. So the entire procedure is performed by observing the flow of contrast. And even though embolization can be determined by the reduction in blush of that tumor vascularity, it's all done by inference. So blocking blood vessels can be demonstrated and verified, but the distribution of beads cannot. And if it's a drug that you're trying to deliver and standardize across the entire tumor vasculature, it's very difficult to kind of make that connection that you've embolized the vessels, but you may not have carefully and consistently delivered the drug and provided good coverage throughout that tumor. And despite there being an interest in looking at how some contrast is retained for a short period of time immediately after the embolization as a surrogate to try and demonstrate the effectiveness of that embolization procedure, we know that this can be done, and Dr. Peter Littler will actually talk about his experience in this, and there is a correlation between the extent of the embolization and the outcome of the patient. So we knew that there was an interest in trying to take it a step further and understand how effective each embolization was in terms of the potential outcome. So it was used as a predictive tool, this retention of contrast. So we started formulating a rationale for developing a radio-opaque bead. And some of the things that kind of stood out during the discussions that we had with many physicians during this time was that despite Lipiodol, which is very radio-opaque and very imageable, the location of the treatment, of the therapy, or of the drug is not necessarily aligned with where the Lipiodol deposits within the liver and within the tumors. As we've already mentioned, traditional beads cannot be properly visualized. And the other thing was that the endpoint is always determined by the reduction in flow of contrast agents. So again, the extent of the embolization is determined by inference, by that reduction in flow. And we were thinking, you know, could there be more to a further visual aid that would help determine a very effective endpoint? And at the same time, this is when cone beam CT was becoming widespread within catheter labs. So this was an additional tool that really made this technology a viable option. And we took all of those considerations and we started developing a new product, which was finally called DC Bead LUMI. So before I go further and talk about some of the technical developments and the features of DC Bead LUMI, I'm just going to do a virtual walkthrough of the facilities that we have here in the UK in our R&D site. So we have a collection of laboratories, all state of the art. The first one here is our wet chemistry laboratory, where we're able to formulate new materials. And this is where DC Bead LUMI was developed. So we have reaction vessels, we have the ability to make these materials, to purify them, to make sure that they're of the right standard and the right biocompatibility. We also have extensive characterization techniques and methodologies. As you can imagine, with a microsphere, the beads that we make, we want to understand their sizes, and we have both manual and automated sizing techniques where we're able to gather a large amount of data on how tightly calibrated the spheres are. Here you can see on the right-hand side a bioindenter, which is able to analyze single beads for their compressive modulus, and that's important to understand how they behave inside catheters. We've got a scanning electron microscope, which allows us to look at the surface and also the surface chemistry. We also have extensive analytical equipment for all of the release testing that we would have to do for manufacturing. So this allows us to do extensive characterization to really understand the materials we develop before we transfer them into manufacturing. So hopefully that gives you a glimpse of some of the activities that were behind developing DC Bead LUMI. So just moving on quickly, the concept of a radio-opaque particulate for embolization has been around for many years, and there have been many attempts at developing these. But they've all fallen short in the past, whether it's a toxicity issue, a physical issue such as aggregation, or the inability to deliver them through a microcatheter. So despite this kind of attempt going back 20, 25 years, it was only when DC Bead LUMI was launched that we demonstrated the ability to actually overcome some of these technical challenges. And just very simply high level, what we have done is we have actually taken DC bead. So that was a very much intentional strategy to not start with a new material, but to take DC bead itself and to chemically bind an iodine moiety to it. So it's very similar to contrast agent. So we have chemically bound in an irreversible manner a contrast agent to DC bead. And we did a lot of testing to make sure we had the right level of radiopacity as well as the right handling properties, because the physical properties of the bead does change when you add a moiety such as iodine. And because we did start with DC bead, then we retained a lot of the features that were important to the product. The first one, that it's loadable with drugs, and here you can see the transformation of the beads after being loaded with both doxorubicin or an irinotecan. Because we use the same chemistry, we're able to maintain the same loading dose as well as maximum recommended dose per treatment. The preparation method, and in particular the loading methods, are slightly different. Again, because the physical properties have changed marginally, there are some slight differences in the way that these are handled. But we have ample methodologies for loading that we provide to the pharmacists so that they can prepare the products for you. And then we obviously need to know how the drug is eluted, and the elution of the drug in a bench model falls within the window of elution that is provided by DC bead. So it's slightly more controlled, it's slightly prolonged, but it falls within that window of all the clinical evidence that currently exists. So apologies for the wording, but this was demanded by our regulators. The indication allows for the product to be used in 3 ways. Firstly, without drug loading, so in a bland sense, and there, we have had many examples presented by physicians where they have used it without a drug, so in maybe other indications beyond liver cancer. And then in the two major ones, which is combining with doxorubicin for treating primary liver cancer and combining with irinotecan for treating colorectal metastases. And just walking through again the development, Lepidol is a great indicator of the tumor. It does not get broken down inside any tumorous tissue, so it appears as if it's targeting that tumor. The reality is it permeates through the entire liver. DebTase technology provided consistency in terms of dosing, in terms of administration, in terms of drug release, whilst reducing the systemic exposure. But LumiTase, as we've called it, takes it one step further. And as you can see, it's imageable under all standard clinical imaging modalities. There's an image there of intraprocedural shot. This is a single shot, and these can be taken throughout the procedure to show where the beads are accumulating. A snapshot from a DSA image shows where the beads have aggregated. You see that kind of embossed effect, and that really shows you where the beads are. And then finally, in that cone beam CT, this was one of the very first patients that was treated. You can see each of the individual vessels are pacified there. And the advantage over Lepidol is that it is more discrete. It doesn't blank out the entire vessel, tumor, so you can see the discrete vessels. And following a number of the initial cases that were attended, we gathered the feedback from physicians. We learned about how the product was being handled, and we drafted and published some technical considerations. And there's a double approach here in that this allows very clear instructions as to how to use the product for the very first time. It is slightly different to DC bead in the way it should be prepared and it should be handled. And then as the physician becomes experienced with the handling of the product, as well as some of the imaging feedback they receive, then we suggest a slight switch towards using maybe smaller catheters, slightly different formulation of contrast agent, and a slightly different technique. And Dr. Peter Littler will walk you through his personal experience of how he started and how he's developed the technique. But this information is readily available, and I'm more than happy to have a conversation with anyone or answer any questions in this area. So with no further ado, as I've mentioned before, if there are any questions, please capture them on the Q&A. But I'm now pleased to welcome Dr. Peter Littler, who's going to be talking through his clinical experience.
I'm Peter Littler. I'm an interventional radiologist from Newcastle in the north of England. And I just want to talk over the next sort of 20 minutes, 30 minutes or so about my experience using DC bead and also our changeover to increasingly use DC Bead LUMI and where I see it fitting in to my practice. So I work in a hospital in the north of England. We're a tertiary centre for HPB, many other services. We've got a catchment of about just under 4 million. And our liver cancer service includes transplant, liver surgery, hepatology, oncology, and of course, interventional radiology. Now, we've been using DC bead since 2008 and have done well over 1,000 cases. We've, over the last few years, we've used 100 to 300 microns as our sort of standard first treatment for lesions. But we've noted a trend to smaller beads with the sort of view or the aim to enable greater tumor penetration. And so we were early adopters of M1 DC beads. That's the 70 to 150 size back in 2013. Have done over 300 cases. And we really use them for second or third treatments when the vascular supply is not so great, and also as initial first treatments for small lesions or lesions that are relatively hypovascular. And I was initially slightly concerned that using a smaller bead may lead to greater parenchymal injury or biliary injury, but we found no increase in our cohort of patients in complications with switching to the smaller bead. So there's been a lot of advances in technology we've been lucky enough to benefit from over the last few years. One of the main ones, of course, and Pedro touched on this, is cone beam CT, which has been a great benefit for TACE cases, not only finding the vessels that supply the lesion and being able to give a more super selective treatment, but also I'll show in the next slide, you can see quite nicely the uptake in the tumour at the end of the case and potentially see areas that are missed or what have you. So I'll show that on the next slide. Catheter technology has advanced as well, and also the bead technology itself, as we're sort of focusing on with this presentation. So yeah, cone beam CT I think has been fantastic. Here's one case showing at the end of the case. This is just standard DC bead 1 to 300. And you can see at the end of the case you've got trapped contrast within the treated tumour, but a sort of wedge shape here that doesn't that has no contrast trapped within it. And then a month later you do the scan, and lo and behold, you've got this wedge-shaped area of residual disease. So you can sort of predict the response really for following your case of how the patient's likely to do. And so when I talk to the patients, I can say, looks fantastic, I'm optimistic that we'll see it on the scan in a month. Or if I've missed a bit, we can either then go back at the same procedure to look for a missed vessel, for example, or you can get them back early for retreatments. So I think cone beam CT has been a great benefit. So I just thought, because this is a live webinar, we'd throw a few questions in. So the first question, just to gauge the audience's practice really, you can just say, could you just answer the question popping up on your screen? How do you perform your TACE procedures? Is it all DEB TACE, 75% DEB TACE, 25% CTACE, 50-50 DEB TACE to CTACE, 25% DEB TACE or 7 to 75% CTACE, or all CTACE? If you just submit your responses there, it'll give us an idea of people's practice, because I know it does vary hugely. That's interesting. So it's perhaps not surprising at a DEB TACE webinar. Quite a lot of people are performing a lot of DEB TACE out there. So we've got 33% are 100% DEB TACE, which is, I'm 100% DEB TACE as well. 75% DEB TACE, 25% CTACE is 33%. So we've got 2/3 are either all DEB TACE or 75% DEB TACE. And then there's some smaller numbers there, 17%, 25% DEB TACE, 75% CTACE. So the vast majority here are all or almost all DEB TACE procedures. Okay, moving on. So next question, have you ever used radiopaque DC Bead LUMI in your TACE procedures? Yes or no? I'll just submit my response there. Give you a few seconds. Right, so 20% of the people watching this have used DC Bead LUMI before, but 80% haven't. So there's obviously a lot of interest there with people sort of tuning in to see what it's all about. Okay, so moving on. Right, so why would you use, or why did I use radiopaque TACE? Well, I think it promotes good technique, because I think you want to be as selective as possible with your treatments. You don't want to see a lot of non-target embolization at the MDT. The LUMI bead doesn't disappear, it's there forever. So wherever you put it, you'll see it. So it kind of focuses the mind, should I say. And I think during the procedure, you get a better visualization of the embolization as it happens, and can adjust your catheter position sometimes when you can see the non-target embolization perhaps more clearly than you would have done with the standard DC bead. And also, one of the things I think is most important is that you get this permanent tumor staining. And I think that can act as a fiducial marker to optimize ablation. And that can be as a planned thing. So you do the LUMI TACE and then go to ablation. Or it can even be years later when you get a nodule of recurrence and you have the tumor marked forever with the LUMI TACE, and then you have a nodule of recurrence, and then you can go and ablate it. And it optimizes the needle positioning and the location of for a CT guided ablation. So that's where I think LUMI is really valuable. So just case selection. I mean, you can use LUMI for any patient who you could use DC bead on. But I prefer treating sort of 1 or 2 lesions. I really like them when they're relatively peripheral and hypervascular, and then I think you can get some really lovely results. And I do use it a lot to mark for ablation. And as I say, you could use it to make smaller lesions, so sub-centimeter lesions, sub-3 centimeter lesions, more conspicuous for CT guided ablation. You can take lesions that are just over 3 centimeters and combine them with TACE. Do the LUMI TACE and then move early to ablation to expand your margins to enable you to do a better job. Lesions that are larger than 3 centimeters, also potential to downsize them and ablate them in the future. And as I mentioned just before about the larger lesions, so you can take lesions 7+ centimeters in size, and years later you can get a nodule of recurrence that then you can go and ablate easily, because you can see exactly where you should put your needle on the CT scan. So just some technical notes. It's slightly different. I don't think it's particularly difficult, but it's just slightly different than your standard DC bead cases. Most opt for the 70 to 150 micron beads. The beads are slightly stiffer, and we know that the normal DC beads shrink a little when they're loaded. Perhaps this is something we can talk about with Pedro in the Q&A after this. You should not use any saline at all, because the beads are a little bit denser. So to suspend them nicely in the solution, you need quite viscous contrast. So you need to use 300 to 350 contrast, and you don't use saline even for flushes. One of the things, the next point is the main one really I wanted to say, which is that people can be put off early on by microcatheter blockages, which you can get if you flush with saline or haven't flushed the catheters first. So what I found after a couple of disappointments with my first few cases was that if you flush and lock the microcatheter with contrast via a 3-way tap at the start, you don't tend to have any problems with catheter blockages. And so as soon as I started doing that, I've had no more blockages since. And I've used catheters 2.7 French down to 2 French catheters without issue. It's for 2 French catheters, if you're going to use those to get really selective, you need to go with 300 contrast. So I think if you use 350 contrast, you have to really press very hard to get it through because it's so viscous. So to avoid giving yourself a nosebleed, stick with 300 contrast for that. And go slow when you're injecting, which is good advice for any DC bead TACE. So 1 ml a minute, as recommended by Lencioni et al. Okay, so I thought I'd prepare a little video. So this is Ribena rather than or blackcurrant squash rather than DC bead LUMI. But I thought I'd just show you the flushing the microcatheter and locking the 3-way taps. I think this is absolutely crucial. If you just do this, and then you can crack on and do the case, no problems, no catheter blockages. Okay, so I'll just show you this little video. So this is the contrast, just flushing the microcatheter, dead easy. And then you turn the 3-way tap to lock the microcatheter, and then off you go. You can start delivering the treatment. I tend to just draw at 1 ml at a time and get the radiographer to put up the timer so I can see a minute tick by and just try and stick to 1 ml a minute as best I can. Okay. So just want to show you 6 cases, if that's okay, just to show my early experiences of the first case I did, and various different cases showing how it's been useful with ablation and what have you. So this first case was quite a big tumour, just under 6 centimetres, 75-year-old guy, cirrhosis, had metabolic risk factors, which we find very common these days, performance status 2, good liver function. Sorry, it was 7 centimetres actually. Here's the MRI before we did it. So arteria is not the best MRI in the world, but you can see there's the lesion there. A bit of arterial enhancement, bit of washout, a pseudo capsule you can see around the edge there. So this was the angiogram when we did our first case. So even though it's hypervascular, it didn't really show brilliantly on the DSA, but on the cone beam CT, it was absolutely fantastic, and you could see a couple of vessels going into it. So we put our mic catheter in these 2 vessels and deliver the treatment. You can see very nicely these are a couple of single shot images whilst we were doing it. So this is an earlier one here, and then a later one. You can see really nicely the staining and the LUMI within the tumour, and you can also see very nicely the little non-target branches filling. We gave 97 milligrams of LUMI, M1 to pre-stasis, and immediately post-TACE, we did the cone beam CT on table, and you can see this lovely uptake within the tumour of both trap contrast and LUMI. At 1 month follow-up CT, so this is where it differed for normal DC bead TACE with CT follow-up, and that you compare a lot to the unenhanced scan. So you can see on the left, we've got the unenhanced CT. You can see this is the LUMI, it's permanently staining the tumour. And you can see an area of enhancement at the margins, demonstrating residual disease. So comparison with unenhanced scan was the thing I learned here. There you can see the lesion nicely demonstrated there, and we've got a complete response at 3 months after the second LUMI TACE. And then at 6 months, we did a CT scan that showed possible nodule of recurrence, and we did an MR to see how LUMI would look on MR. And we found subtracted MR with contrast showed very nicely the little nodule of recurrence. So MR was pretty good and can be an excellent problem-solving tool, I think. So we had this very tiny thing, and so we decided just to keep an eye on it. And then over a year later, it started to grow a little. So we decided to go and do an ablation. And so you can see here, this is at 3 months, you can see the lesion there. There's the little nodule. And what you get over time is the lesion tends to shrink in size, and you get increased density. So as the LUMI sort of, or the lesion reduces in size, the LUMI becomes more crowded and you get a more dense lesion. And you know that the lesion's at the sort of top anterior lateral edge. And so it's very easy with CT and ultrasound as well to put the needle in the right position and do a nice ablation of that area. So that was at 15 months later. So much, I was never expecting to use this LUMI for a potential ablation in this case, but it was actually quite useful in the end. So learning points for our first case, I know I've covered most of these, but on CT, the difference between normal DC bead and LUMI was that we compare with the unenhanced scan. Contrast MR with subtraction was useful to problem solve and demonstrate a small nodule of residual disease. And 15 months later, the LUMI was quite useful in optimizing ablation targeting. So second case, we got a 63-year-old man, cirrhosis of unknown etiology, previous bladder CA, pretty fit with good liver function. And there you can see the big lesion up there in segment sort of 7-8 of the liver. We did a LUMI TACE there. We got we did a cone beam CT angiograms and put the microcatheter in position. And this is an early picture after we just injected a small amount of LUMI, and you can start to see sort of staining within the lesion. And here is at the end when we had pre-stasis. You can see this fantastic uptake within the lesion of both contrast and LUMI. So this was the cone beam CT angio we did before we did the embolization. And then immediately following the embolization, you can see how nicely the lesion is stained with LUMI and contrast there. And there it is. So on this is the coronal. So you can see how nice it looks. You can see it's beautifully taken up the contrast. And this was a single treatment. So one treatment, 150 milligrams. I used the whole lot. Just about got to pre-stasis. And I particularly like this picture because it reminds me of the Eye of Sauron. So I thought I'd throw that one in there. At 1 month, we got complete response. You can see the contrast has now washed out that had or been broken down, that had been trapped by the LUMI. And all you see at 1 month is the LUMI itself. So this is LUMI within vessels. We saw no evidence of any enhancement, and the lesion started to shrink. So complete response at 1 month. And then we did an MR at 12 months during the follow-up. We normally do 1 month and then 3 monthly out to 2 years. And then if it still shows no recurrence, then we move it to 6 monthly. So at 12 months, complete response still. And then at 2 years, the nodule recurrence was noted right at the top. There's just under the diaphragm, right at the top at the back of the lesion, this little nodular recurrence, really tough to see. But because we had the lesion beautifully stained with LUMI, we could easily guide the needle into the correct place because we knew where the nodule was in relation to the lesion itself. And so if you've got CT as part of your ablation practice, then I think it's fantastic. Even at a late stage, even 2 years later on a lesion you never think you're going to ablate, it became very useful just to help guide the needle in to do a nice ablation of a nodule of recurrence. So on to the third case. This was a patient, a 67-year-old with NASH cirrhosis and a 3.7 centimeter HCC within the right lobe of the liver. So enhances, washes out. So here's the LUMI TACE procedure. So there's our lesion staining nicely on the DSA. This is towards the end of the LUMI TACE procedure. You can see non-target embolization shown really nicely there, and the lesion itself demonstrated well. So this was just to compare. This is the DSA and then the cone beam CT coronal image immediately post the TACE, showing how nicely it's taken up the LUMI and contrast. So this is the cone beam CT immediately following the TACE. And then a CT at 18 months shows the lesion has markedly reduced in size and become more dense, obviously because the contrast has long gone at this point. But the lesion's really got much smaller in size. So we've gone from a lesion that is 3.7 centimeters in size down to a lesion that's less than 2 centimeters in size, and may have been, or we viewed it as outside of a reasonable size for ablation at the time. Now becomes a potential ablation target, particularly as we found that we had a bit of enhancement develop at the bottom. So it became more isointensive, but a focus of enhancement happened at the bottom of the lesion, 18 months post LUMI. So we thought this was enough. We thought this is likely to be a little bit of recurrent disease. And so we've got a perfect target to do an ablation. So this is something we were also weren't particularly expecting, is when we do quite a lot of ablation with ultrasound as well. So when we looked at the lesion with ultrasound, we could see the area we treated with LUMI was bright, and the recurrence at the bottom of the lesion was dark. So we could use this also to target for ablation. And you can see here is just a few CT slices through the lesion, and this is the top of the ablation needle. There's the lesion, here's the ablation needle, gone nicely through it, there you are. And then after we do the ablation, you can see the margins of the lesion really nicely. You can see the margins of the ablation, so you can check that you've done a proper job and you've achieved adequate margins. So I think this is really a nice use of LUMI. So this was downsizing to ablation of some recurrence. So case 4, this is a lesion in an awful position for ablation. So it's tucked up high in segment 8, right at the front of the liver, lung all around. So this was a 57-year-old ALD cirrhosis, previous 3 centimeter segment 4 HCC treated with ablation, performance state 0, child PUA, and he had this little HCC in segment 8. And so we did a LUMI. Because there's very few, there's very small vessels within this, we only got a tiny bit of LUMI within the lesion, and we had some LUMI within staining in the vessels around the lesion, which we could use as a fiducial marker to guide the ablation, which we did. And you can see nicely the lesion is included within that ablation zone there. One thing that's worth a mention is the combination of TACE with ablation. If you do the TACE and then ablate shortly afterwards, then you can push the margins and get a bigger ablation. So these were exactly the same ablations with this lesion on the left, 100 watts for 10 minutes, and you got a 3.7 by 3 centimeter ablation zone. Here's one we did a LUMI TACE on, and then the next day did exactly the same ablation, 100 watts for 10 minutes, and we pushed that out to 4.6 by 4.1 centimeter ablation zone. So the combination of TACE then ablation, you can do bigger ablations and achieve margins. So just a couple of cases left to go through. This is a 58-year-old male, 3.7 centimeter hypervascular lesion in a non-cirrhotic liver. We did a biopsy and it showed a moderate to poorly differentiated HCC, and his AFP was just under 5,000. He was fit and had good liver function. So AFP just under 5,000, 3.7 centimeter HCC. So we planned to do a LUMI TACE and ablation in the same sitting. We didn't want to kind of wait around too long with it being moderate to poorly differentiated and such a high AFP. We decided to do the TACE, which we did a very selective TACE with LUMI. You can see there. And then, because this lesion was right on the gallbladder, right along, contacting the gallbladder from a long distance, we did a combination with the surgeons, and the surgeons removed the gallbladder, and we could guide the needles in and do an ablation. So you can see this was the ultrasound before the LUMI TACE, and then after you can see there's a bright area within it, which is where the LUMI TACE is accumulated. And there's the lesion on table. Lots of fluid put in around by the surgeons to float things away, and the gallbladder's removed, and then we did put 2 needles in and did a microwave ablation of that. 3-month post-ablation CT, you can see the LUMI within the lesion, and there's the ablation zone there. And immediately after we did the LUMI and ablation, is AFP dropped from just under 5,000 to nothing, and so which is great response. And then I've just looked in the last few days, and he's had a CT recently at 2 years post treatment, and he's a complete response, sustained complete response. And the ablation zone has just reduced in size, and you've just got a clustering of the LUMI there centrally. So a really nice result there in somebody with a high AFP and a moderate to poorly differentiated lesion. And the last case I wanted to show you is just a quick one. We've got a lesion here in an awkward spot behind the right portal vein. We decided to do a LUMI TACE on it to mark it. And it was a small lesion, small vessels, but we got a bit of LUMI into the lesion, and we could use that nicely just to guide in the ablation needle and carry out the ablation. So it helps just really target that lesion nicely to hopefully get best results. So a couple more questions for you. Do you do ablation in your center? Or is ablation done in your center, I should say? Yes. Ultrasound guided? Yes. CT guided? Yes. Cone beam CT guided? Yes. CT and ultrasound guided? Or no, we don't do ablation. Right. So same. So it's yes, CT and ultrasound guided in 86%, which is what we do, and yes, cone beam CT guided in 14%. So that's an interesting option that I think people do practice, and I would be quite interested in trying that myself sometimes. But I think CT and ultrasound guided is the vast majority, 86%. So next question. Do you see the value of TACE tumor staining to help optimize ablation? So the options are yes, we already use it. Yes, we plan to start using it, or no, I don't see the advantage of it. Yes, we already use it, 71%. Yes, we plan to start using it, 29%. And everybody sees the value of TACE staining to optimize ablation. So that's interesting. Right. So we published our early experience with using LUMI, and it got published in CBIR in 2019. It's open access, so if you want to have a look at it, it's easy to get hold of. I'm just going to touch on some of the points that we found. So we looked at 55 TACEs in our first 40 patients. We only needed 1.4 LUMI TACEs per patient. Mean age was 70. We had NAFLD and ALD cases with good liver function made up well over 50% of our cases. 70% were cirrhotic, mostly single lesions, and they widely varied in size, as you can see down here, with nearly a quarter over 5 centimeters in size. We found really promising response rates, with overall response rates made up of complete response and partial response in over 90% of cases, and with our best overall response rate 60% at 6 months. Sorry, complete response rate of 60% at 6 months. So really promising results there. We looked in the literature to see what was out there, and there's not a lot actually at the moment. But Lencioni had published an abstract in ASCO in 2018. And he had a similar number of patients and similar complete and objective response rates to us. We found We found that the LUMI was well tolerated, and we noticed no difference compared to our normal DC Bead TACE experience. So 81% of patients reported no adverse event, and we had 3 patients with grade 2 or 3 issues around post-embolization syndrome, just requiring extended hospital stay or readmission. So that's 3 patients. And 1 patient who had gallstones, and we ablated him, then happened to have a gallstone go into the CBD and cause biliary obstruction, developed an abscess that needed percutaneous drainage, but then he was okay. We looked in the literature, and Aliberti published his data on safety, and found similar to us, 89% reported no adverse event and 11% had mild post-embolization syndromes. So essentially similar to our experience with DC beads. So I think the potential advantages of LUMI to me and to my practice was, I think the slow injection and enhanced visibility promoted good practice for me. So it kept my mind focused, and I could optimize my technique. And I think particularly the permanent bead deposition in the tumors really helps with ablation, either as a planned thing initially or years later when you have a nodular recurrence. I think it's fantastic at marking lesions for ablation, and as I say, a long-term marker for ablation of recurrent nodules. And we have been really encouraged by the responses that we've had so far. So thanks a lot for your attention. Now I think we would go over to a Q&A. So hopefully you've been asking some questions. You can put to Pedro and myself. We'll be happy to answer them. I think we've got at least 10 minutes left for a Q&A.
Okay, thanks, Peter. We've had a few questions coming. We had some pre-submitted questions, and we've had one come in so far. maybe kick off with a clinical one. So Arturo Fuego online has asked whether you have treated only liver or whether you have performed any prostate embolizations with LUMI.
Ah, yes. So yeah, only liver so far. We haven't gone to prostate as well, but that's definitely an interesting area. No, we've stuck with liver. Stuck with liver so far.
Okay, maybe I can add to that. I can't speak from a clinical perspective, but I do know that there have been quite a few cases performed in prostate, and certainly some very strong feedback in terms of the visualization and the distribution of the bead. So it's clearly visible within the prostate organ, and there's been some interesting output from certainly from the US and also from some UK studies.
So if we go to some of the questions we had pre-submitted, Pedro, can I ask you a couple of questions?
For sure. Yep.
So this one came in. How long is LUMI visible for? I think we've touched on some of these in the talk, but
yeah, sure. So as I previously mentioned, the LUMI is produced by combining a radiopaque agent, the form of iodine, very similar to contrast agent, and it's chemically bound to the beads. And during our development, we studied the strength of that bond, and we were unable to actually separate the contrast agent that we'd adhered to the beads. And I think all the clinical evidence, as well as all the preclinical evidence we generated before we launched the product, demonstrates that it's permanently radiopaque. So that radiopacity will not diminish or disappear over time.
Thanks. And one question I've always wanted to ask is why do we have potential issues with catheter blockage, do you think? I know we've come up with a way of avoiding that and getting around it, but why are we more likely to block a catheter with LUMI than we are with normal DC bead, do you think?
Yeah, I mean, it's a great question. And we were a little bit taken aback with some of the very early cases where there were reports of catheter blockages. But as you well know, Peter, from the feedback and the work we've done together, the techniques that you've developed have helped overcome that. We did look into this and try to understand the root cause. One of the things that changes when we add the iodine moiety to DC bead is that we change the physical properties, in particular the density and the compressibility of the beads. They happen to be more rigid than DC bead. And even though the combination of bead size and catheters that we recommend still mean that the beads are much smaller than the internal diameter, so there's no need for individual beads to travel through the microcatheter, that rigidity does promote the occasional overlap of beads as they travel down the catheter. So when they come into contact with each other, when they're trying to overtake each other, because that's what happens inside a cath, you have laminar flow. It's the occasion of beads overtaking each other that could lead to a blockage. But the technical considerations that we've developed and we use to educate and users for the first time when they come to use LUMI have been very effective and have overcome all those issues. And we've rarely heard of any catheter blockages since we introduced those recommendations.
Do you have another question has come in? Do you have a recommendation on the best dilution of contrast to LUMI when you're mixing it? I know, for example, that we use 18 of neat contrast, either 300 to 350, and 2 milligrams of 2 mils of the LUMI mixed together, so 20 mils in total. But does that differ to what you recommend? Okay,
yeah, so our technical considerations are staggered in that we recommend some very specific procedural technique for the first few cases to enable the physician to familiarize themselves with the handling of the product and the visible feedback that they get. So we take a very conservative approach. And we recommend a couple of things. Firstly, because the beads have changed and they're more dense, we recommend injecting with pure contrast agent. And that's to maintain a longer suspension time. If they're diluted with saline, we find that the beads settle too quickly, and unless there's permanent mixing, which can be rather irritating, it's best to start off with a high density pure contrast agent. But then as the experience and handling kind of familiarity develops, then we open it up to be able to use lower concentration contrast agents. And as Aliberti demonstrated, that they actually have gone one step further and are actually diluting with saline, which is not necessarily something we recommend, certainly not for the first few cases, because the settling time is very quick. So to start with, use pure contrast with high iodine content, maybe an Omnipaque 350, and then as you develop your familiarity with the beads, then maybe you can reduce down. Because maybe you can give us some feedback as to that process that you went through, Pete, to understand how to start using a smaller microcatheter.
Yeah, absolutely. I found that with 350 contrast, it's more viscous, so they stay in suspension longer. So that was fine, and we use that a lot for the 2.7 French and 2.4 French catheters that we used in our initial cases. But then sometimes you need to use a 2 French catheter, so I wanted to use LUMI with a 2 French catheter, and found that pushing 350 contrast through a 2 French catheters really is quite hard work. So we just switched to 300 contrast, and I just draw up a mil at a time. And by the time you've got the mil in, you haven't got significant settling. So I found 300 contrast with a 2 French catheter and LUMI absolutely fine, no problems at all. So I would have no reservations in recommending that if people want to use a 2 French catheter, just go for 300 contrast and do your normal technique. Yeah, and it's absolutely fine.
And you don't have an urge or a need to go a step further and add saline? As I said, we don't necessarily recommend that, but
I've never felt the need to, really, to be honest. Yeah. I think you're effectively doing that by choosing a contrast with a lower concentration, aren't you, essentially?
That's right, yeah.
So I think 300 contrast is absolutely fine. It does settle out pretty quick with 300, but I think if you just draw up a mil at a time, then it's absolutely fine, no problems at all.
So 1 mil into your injection syringe to reduce that settling.
1 mil into injection syringe from your reservoir. Yeah, that's
okay.
Right. And then get your timer on, and then by the time you've given it over the minutes, you're ready to get a fresh mil in and continue.
Okay, great. So one of the other questions that come in was about particle size and the risk of pulmonary embolism. So one of the things that you probably want to highlight here is that the size that we're offering for LUMI is 70 to 150, and it's centered around the middle point, around 110 microns. The beads are manufactured under very strict conditions, and they're actually checked for size during 2 occasions, during the manufacture itself and after terminal sterilization, just to make sure that whatever we put into the marketplace meets all our specifications. The process eliminates anything smaller than 70 to 80 micron. In fact, there's very little 70 to 80 micron product in this particular size. From a clinical perspective, do you have any concerns, or is there anything you do in particular to avoid any issues such as a pulmonary embolism?
No. I've never seen it. I think if you're doing your angiogram and you saw obvious shunting through to the hepatic veins, then I'd be wary of using a small particle. But you very rarely see that, and I've never had any issues at all. I think it's more of obviously we know from certs that you get cert go to the lungs, but the particle's far smaller with certs, only 30 microns, and I've never had any clinical issues with using the smaller particles. And I know there's competitor products smaller still, and they're in clinical use for TACE. Okay. So I don't think I haven't found it an issue.
Okay, so I've got one question, Pete, if you don't mind, and maybe just start by giving a bit of an explanation. One of the differences with DC Bead LUMI versus DC Bead is that when it's loaded with either doxorubicin or irinotecan, it doesn't change in any way in terms of its physical property. So there's no size change. DC Bead actually shrinks slightly, so you get a reduction in volume. Now, some of the feedback that we've received is that because it doesn't shrink, you essentially have more embolization material per syringe. And some of the feedback we've had is that they reach physicians reach an endpoint at an earlier stage to what they'd expect. Now, having used both DC Bead and DC Bead LUMI, have you noticed a reduced amount of DC Bead LUMI to reach that endpoint? And if so, is there a difference in outcomes between DC Bead and DC Bead LUMI?
So I do think you use a bit less LUMI than you would the standard DC bead. So I do think you use less. So that must mean you with the same amount of particles, you're getting there sooner to pre-stasis. But I haven't noticed any change in outcomes off the back of that. I think just the cases that we gathered together, the retrospective study that we published showed some really nice outcomes with it, and so I've got no concerns that using less of the product is detrimental in any way. It seems to be at least as good as standard DC bead in our experience, and we're probably getting towards 100 cases now.
Wow, okay.
I do think we use a little bit less. So sometimes you might get away with one syringe full when you might have used more than one in a standard case.
Yeah, DC bead reduces in diameter by about 30%, which actually translates to nearly a 50% reduction in volume. So the exact amount used for each of the products is not easy to gauge, because you do end up with more LUMI, more volume of LUMI per syringe. What we have heard is that they use less syringes per case, and sometimes when they'd expect to use 2, they only ended up using 1. In terms of the volume of product, it may be similar.
Right. Yeah. I think we're coming to the end of our hour now, Pedro.
We are. I just want to thank everybody for joining us. It's been a privilege to be able to share both our development and to have Peter Lissler with us share his clinical experience. I'd just like to thank everybody and say goodbye. Thank you.
Thank you very much.